Welcome to another installment of No Smoke, Just Vapor. Today we are joined by Dr. Kgosi Letlape, who's an ophthalmologist as well as a healthcare leader in South Africa, very well known for his advocacy for harm reduction. Dr. Letlape, thank you very much for joining us today.
Thank you for inviting me.
Dr. Letlape, there's a lot that's been said where this tobacco control bill is concerned. We know it's currently sitting with Parliament. Public submissions are closing in a couple of days. And a lot of the people who are against the bill speak about the concept of harm reduction and how the bill does not recognize harm reduction. Can you just tell our viewers what harm reduction is about, and more specifically, how it applies to tobacco control?
Well, I'll give you an example that I've never used before. When you look at governance systems around the world, one of the governance systems that is being promoted is democracy. But when you look at the democracies that we have, they've become harmful to society. If you look at what is happening in the US, it is a democracy. If you look at what is happening in Uganda, it's a democracy, but it's got harmful effects. And we cannot do away with a democracy because you need a form of government. So what you then have to embark upon is how do we reduce the harm associated with democracies? Because we can't do away with democracies. It becomes it's the same as someone that feels they can't do away with their need for nicotine. When we know that there are ways in which the way you access your nicotine can be extremely harmful. The most effective way of getting your nicotine, but the most harmful way of getting your nicotine is through combustible cigarettes. But when you're hooked on nicotine, the question then becomes, are there safer ways or less harmful ways of providing you with your nicotine? That is why in health circles, nicotine replacement therapy has been created. Now, when you look at our bill, in its preamble, it talks about quitting. It does not talk about alternatives to those that can't quit. And as a medical doctor, my first position is quit. But I also understand that there's nearly 1.3 billion smokers in the world. And most, if not all of them, know that smoking is going to harm their health, but they continue smoking. So my duty as a physician is what advice can I give so that they can reduce harm. That's what harm reduction is about. And what it does, it's accepting the fact that, yes, you are nicotine dependent, but the sources of nicotine are not equally harmful. And that's why we talk about harm reduction. Yes, we need democracy, but democracies can be harmful. And the biggest harmful component of democracy is corruption. But corruption is embedded in democracy because democracies are basically auctions to the highest bidder. So what you then have to temper with is how do you reduce corruption? You can't completely eradicate it because it's closely intertwined with human nature. But at certain levels, it becomes extremely harmful to society.
You speak as a medical practitioner, that you would obviously first advocate that the person quit. And understanding that people are addicted to nicotine and that there's NRTs, why is it that the Department of Health does not see this position? Because clearly they've consulted with other medical doctors. Is this an ideology we're dealing with? Help us understand why medical doctors see it differently to how you would see it.
One of the challenges, it's not that medical doctors see it differently. It's that medical doctors are not educated about nicotine. The sum total of my medical education about nicotine is quit or die, which is embodied in the current proposals of the tobacco bill. And that's the sum total of our education. It is not dissimilar to what happened earlier in the fight or in dealing with HIV, where patients were more knowledgeable than doctors. And they used to come to doctors and say, this is what's available in San Francisco. This is what's available out there. Have you heard about triple therapy? Have you heard about dual therapy? Have you heard about ARVs? And the patients knew more about HIV because when we came out of medical school in the 80s, there was no HIV. So it's something that wasn't there. But currently, even the students that we produce, the knowledge about nicotine is very scant or non-existent. So basically, our teaching around nicotine has been a moralistic teaching. It's about morals. It's not about science. It's not about medicine. It's about this is bad for you. If you remember back in the earlier days around HIV, it was also a moral issue. They were thrown out of church. They were thrown out of homes. There was a moralistic approach. And when you said, people are having sex anyway, they say, no, sex is bad for children. See, I'm not saying it's good or bad for anybody, but they are doing it. And they are not doing it safely. When we tried to introduce condoms, you remember Love Life, and the backlash that they had to say, you are encouraging children to have sex. No, children are already having sex. And what we're just doing is to teach them about safe sexual choices, safe sexual practices. That's why we're introducing condoms. And that's to reduce the harm associated with sex, acquiring sexually transmitted diseases, including HIV. And how do you reduce your chances because you can't stay away from sex? There are people that would say, abstain. But there are some people for whom abstinence is not a choice. It's the same thing in HIV and AIDS. There are people that say quit, but quitting is not an option for people that are addicted. And it is quite sad to see the department regress to quit or die attitudes, which is not what we do. My oath is an oath to help, not to judge. What has come out is a document of judgment. It's like a manifesto of a religious cult. Yes. And that's quite sad. But where does it come from? When you read our preamble, embedded in the preamble is deference to the World Health Organization. And that is the source of the problem for the policies framed by this government and most of the developing world, low to middle income countries. They take their health cue from the WHO. And in this regard, the WHO is misleading countries. And countries that have no agency to think for themselves, countries that don't look at the science, despite what the boss says, will come up with policies that are inappropriate for today. Policies that will increase harm to people that use nicotine. So the primary problem for our bill is embedded in the misrepresentation of alternatives to combustible cigarette by the World Health Organization.
But you spoke, Dr. Letlape, you spoke about back then when it was the fight with HIV and AIDS and how promoting condoms instead of calling for abstinence was said you are encouraging young people. And fast forward in 2023, you have the same arguments that are being brought forth by the likes of the Department of Health to say the moment you promote alternatives, I mean, we represent the vaping industry, for example, you promoting vaping as a less harmful alternative is actually meant to, they call it to get a new generation of nicotine addicts, young people. So how do we balance those narratives where, and on one hand, we want to protect young people, obviously, but then you want to also make less harmful alternatives available to smokers who want something that is less harmful. How does a country like ours deal with these two important conversations?
Yeah. Youth uptake is something that should concern us. If you go back to the social behavior, teenage pregnancies destroy the futures of young women. So we should be concerned about early debut in sex, unsafe sex, prevention of pregnancies, being mindful of what happens in society. So youth uptake should be something that concerns us. But what we should be doing is to be saying, adults are dying from tobacco-related diseases. How do we save the adults? And how do we educate the youth? That would be a responsible approach. Not an approach that says we're so concerned about youth uptake that we don't care about the adults that die. Because that's effectively what this policy represents. Now, you'll see things that don't make sense. Where in the bill, they'll demonize nicotine, but make an exception for nicotine replacement therapy. I mean, nicotine is nicotine. Whether you get it from a tobacco industry, from an independent producer, or from a pharmaceutical company, largely it's all derived from tobacco. There are pockets where you can produce synthetic nicotine. But the nicotine that comes from pharma is not holier than nicotine that comes from elsewhere. So why would you have an irrational policy that tries to make that distinction? And you can see that something has gone horribly wrong when we as physicians can promote nicotine replacement therapy. But when you can get it for yourself over the counter, when we should worry about its standards, its production, its safety, we say, no. If you're getting it from elsewhere, it's bad. But if you're getting it by prescription, it's good. It just doesn't make sense. Because nicotine is nicotine. You know, it reminds me of the thing where if you call a disadvantaged group with a derogatory name, it's not acceptable. But if we deprecate ourselves, it's acceptable. It doesn't make sense. And if you're going to use the K word on me and you white, it's not acceptable. Why would it be acceptable if I use it on myself or if another fellow African uses it on me? Doesn't make sense. So you can see that there's a lot here that doesn't make sense. And part of it is that if you go back into the history of smoking and the untruths that came from the industry, there are people that are still stuck in that mode. And that creates part of the problem that we have today. But what is said is that you now see a role reversal, where the industry lied 60 years ago about the harmful effects of tobacco. You now have governments and the WHO now lying about less harmful products. Sometimes even saying to people, the less harmful products are more harmful than the most harmful products. When there are studies that show toxicological components are different. They are greatly reduced to the extent that in the US, the FDA have evaluated the claims that came from industry about reduced harmful components. So in the FDA, you find three things. One, they've been able to grant smokeless tobacco snus to make a health claim that there's a public health benefit. There's a health benefit from switching from combustible tobacco to smokeless tobacco in the form of snus. They've allowed vaping to be able to talk about a public health benefit. So snus is a health benefit. Vaping is a public health benefit. Heat-not-burn product called IQOS has been allowed to make a reduced exposure claim. We've known for the last 60 years what are the harmful components, what are the chemicals that are carcinogenic. And analysis shows that some of the different aerosols have greatly reduced toxic components. Now you have a bill that says all these things are the same. This is now hocus pocus. This is not science. This is not truth. And it is sad to have come to a point when we are a democracy and we now have to deal with this issue. The point I wanted to make is that smoking is considered a sin. The tax that's associated with it's a sin tax. Yeah. So you have this moral creep in terms of how we look at people who smoke. And when you look at the issues and the bill that is there, it's like people who smoke are not human and they do not have human rights. And we shouldn't lift a finger to save their lives.
Dr. Letlape, that's all the time we have for today. Unfortunately, there's so much we could talk about on this bill and the concept of harm reduction and how the country can look at it very differently. Thank you very much for joining us on this episode. And again, don't forget to subscribe to the channel, to like, share as we continue this conversation on vaping as a No Smoke, No Vapor episode that was brought to you by the Vapour Products Association of South Africa.